It's actually tough to learn the whole antifungal drugs without having a firm knowledge of the fungal infections. So in this video, I will try my level best to help you guys in remembering these drugs along with the infections in which they are given to the patient. So let's start with our first drug, that is amphotericin B. So amphotericin B is actually a naturally occurring pollene and it is derived from Streptomyces nullosus. The main point here is its mechanism of action. So its site of action is cell membrane and it has both portions, hydrophobic portion as well as lipophilic segment. So actually in case of amphotericin B, there is formation of hydrophobic interaction between lipophilic segment of this pollene, that is our amphotericin B, and sterol, that is ergosterol in case of the fungus. So as a result of hydrophobic interaction, there are formation of pores and electrolytes and small molecules. They leak out of the cell through these pores. As a result, there is cell death. So in order to remember the antifungal spectrum, let me show you this figure. This is actually derived from Lipin coat and it will help you in remembering the spectrum. So here is our fungus and it exists in two forms. One is yeast and other is the mold form, and it can also exist in both forms, dimorphic. So the yeast exists, we have three. One is the Candida species, other is Cryptococcus neoformans, and the third one is Pneumocystitis gyrosa. Here, in case of molds, we have Aspergillus, Dermatophytes, and Mucormycosis, and the other remaining ones are covered in dimorphic. So, if you remember these CCP and ADM, then the remaining ones will be dimorphic. So, our amphotericin B, it actually provides activity against these two, the first two, Candida species and Cryptococcus neoformans, as well as Aspergillus and mucormycosis. It's actually the drug of choice for these infections. It also covers these three, the above three. Okay. So now let's move toward the pharmacokinetics of this drug. It is given slowly in IV form, and mostly it's co-formulated with in the form of liposomal formulations. The purpose of creating these liposomes is to decrease the renal toxicity that is caused by these drugs, as well as to decrease the inferior toxicity. We will discuss these in the adverse effects. Mostly it is eliminated by urine as well as by hepatic metabolism, and it binds to plasma protein. It can cross placenta, but it cannot cross blood-brain barrier. Its concentration in CSF, vitreous humor, as well as in amniotic fluid is low. So now let's talk about the adverse effects. So the fever, chills, and muscle spasm, they are actually infusion reactions. So 1 to 3 hours later, after starting the IV dose, these symptoms they appear. Okay, next is renal impairment. So it actually decreases the GFR, and it can cause acute tubular acidosis, as well as there can be decrease in the synthesis of erythropoietin. Hypotension is actually a shock-like fall in blood pressure that can occur along with the hypokalemia, and if the patient is taking digoxin, so care should be kept. Okay, next is thrombophlebitis. It can be decreased by giving the patient heparin. Next antifungal drug is flucytosine. Flucytosine is actually a pyrimidine anti-metabolite. It is given orally and is eliminated by the urine. So flucytosine can be converted into 5-fluorouracil by the metabolism of intestinal bacteria, and this 5-fluorouracil that is formed by the metabolism by these intestinal bacteria can be detected. So the important point is actually here again is mechanism of action of flucytosine. Okay, so now mechanism of action. There are two enzymes that are involved. One is a permease and other is a cytosine deaminase. Here, the drug actually is converted into 5-fluorouracil by the help of the enzyme cytosine deaminase, and then it is further converted into 5-fluorodeoxyuridine monophosphate, and this is going to disrupt the protein and nucleic acid synthesis. Okay, but how resistance can occur? Obviously by decreasing activity of these enzymes, and so this drug is never given alone. It is always given with in a combination therapy, like here You can see that flucytosine, when given with amphotericin B, is used in the treatment of streptococcal or cryptococcal meningitis, whereas when it's given with itraconazole, it is used in the treatment of chromoblastomycosis. It can be used in the treatment of urinary tract infection that are caused by candida if these are not treated by itraconazole. Now let's move toward the toxicity of these drugs. So it causes thrombocytopenia as well as neutropenia. Both are bone marrow depression disorders. Okay, next is liver dysfunction. It can occur, causes nausea, vomiting, and diarrhea, as well as severe enterocolitis has also been observed. Next, we have azole antifungals, and in this video, we are going to cover triazoles. So we have flo, itra, vori, posa, and isavuconazoles. So what's their mechanism of action? They inhibit the synthesis of ergosterol, and how they inhibit them? So here in case of fungus, we have an enzyme cytochrome P450 isozymes. They catalyze the 14 alpha demethylation of lanosterol. So these triazoles, they inhibit these steps, and as a result, we have inhibition of synthesis of ergosterol. This lanosterol is further converted into ergosterol. So by inhibiting these, we have decreased synthesis of ergosterol. So now let's move toward the clinical uses of these drugs. First, we have fluconazole. It is a drug of choice in case of esophageal and oropharyngeal candidiasis, as well as in the one single oral dose is given in case of the vaginal candidiasis. Next, it can be used in the treatment of candidemia. It's actually the candida, when the candida species are found in the blood, that is known as candidemia. Okay, and now in case of acute treatment of cryptococcus meningitis, the cryptococcal species neoformans that can causes cryptococcal meningitis. So for the acute treatment of this condition, we have amphotericin B with or without flucytosine. That is a drug of choice. But fluconazole can be given as an alternative, but it is less effective as compared to this. But in case of maintenance and secondary prophylaxis, in case of AIDS patient or one with immunocompromised patient, so here in them the fluconazole is a drug of choice in maintenance to prevent the relapse after initial control. So this fluconazole has no role in zygomycosis and aspergillus. Next drug we have itraconazole, and it is broad spectrum antifungal drug. It is a drug of choice for blastomyces, histoplasma, sporothrix, and paracoccidioides. It's alternative for cryptococcus and this one, but it's not given in aspergillus and candida species. It can also be given in case of resistant strain of esophageal candidiasis, and it can also be given in onychomycosis. Now let's move toward the voriconazole. It's also a broad spectrum drug, and it's the drug of choice in case of invasive aspergillosis. And alternative can be given as an alternative in case of candidemia, candidal, esophagitis, and stomatitis in case of AIDS patient. And it's also the drug of choice in case of Fusarium species. Toxicity of these drugs as a whole are given. So let's discuss them before discussing these two. So it causes vomiting. These causes vomiting, diarrhea, rash, hepatotoxicity in case of if there is pre-existing liver dysfunction. And ketoconazole, it can cause gynecomastia, menstrual irregularities, and infertility. They also cause drug involved in drug-drug interactions, and they are inhibitors of P450 enzyme system. Isavuconazole is also a broad spectrum, and it's given as a prodrug, whereas posaconazole is also a broad spectrum drug, and it covers most species of Candida and Aspergillus, and it can be given in case of mucormycosis. And if these species they are resistant, so posaconazole can be given in place of voriconazole. So that's all about the three main antifungal drugs. Hope you will like this video. If you like this video, click on the like button as well as subscribe to the channel. Thank you so much for watching this video.